Good evening, everybody. It is Wednesday evening. I think it's just about 8 p.m. And tonight we are joined by Dr. Q. So we're just going to give it a couple of minutes for everyone to get the notifications. And we're discussing tonight is trying to conceive with PCOS. We are keeping with the theme of PCOS Awareness Month this month. And yeah, so we're gonna, most of our topics this month is going to be on PCOS. Don't forget, guys, we will obviously, we won't forget about all of you when it comes to endometriosis and all the other infertility related topics. We will definitely discuss all of that. Thanks, Leandra. Thanks for joining us. So just give it a couple of minutes. And before Dr. Q is going to be joining us tonight. So if you guys don't know Dr. Q, she's a really fun fertility specialist. She is based in Gauteng. Yeah, so Dr. Q, as I said, is in Gauteng. I think she's just came in. And we'll just wait for a couple of people to join. I see everyone's starting to come in. Hi, guys. Kanye, Miriam. Hi. Hi guys, thank you. Matthew, Lady D, thanks guys for joining us. Again, tonight we're discussing trying to conceive with PCOS, and we're going to be sticking to the theme of PCOS Awareness Month. So most of our topics are going to be on this. So okay, so I'm going to invite Dr. Q now. So, hi everyone's joining. Okay, here we go. Hey, Charles. Hi, Kanye. Hey, Dr. Q. How are you?
Good. Thanks. And yourself?
Good. Thank you, Doc. Thanks again for joining
us.
Yeah. Hi. So tonight I was just telling everyone we are sticking to the PCOS awareness theme. PCOS Awareness Month theme. And tonight's topic is trying to conceive with PCOS. And it's quite a big topic. You know, there's so many things when it comes to PCOS. It's like, take this medication, can't take that medication. But before we get into any of those, and we've got lots of questions to get through tonight, Doc. Quite a lot of questions. And if you guys have any questions, please put it in the comment section. We are going to see it at the end of the talk. If we have time, we'll definitely get through it, try and get through everything. But Doc, please introduce yourself. I don't know if you've got a song about it. You're going to rap a song for us or something.
I wish I could. Maybe I'm Dr. Q, and I'm the cute one.
Well done. Well done. If you guys know Dr. Q's vagina rap, yeah, you should check it out on Instagram. It's actually quite hilarious. It's really a good one. So, Doc, please introduce yourself to the ladies. Tell them who you are and where you're from.
Okay, hi everybody. I'm Dr. Q. Q stands for my beautiful click Zulu name, which is Insile. It means truthful. So I'm Dr. Q Diale, and I'm an obstetrician, gynecologist, and a fertility specialist. I work in Family Matters Fertility Center. We help make people's dreams come true by helping them to get their families started. And we are based in Pretoria and in Centurion. So yeah.
Awesome.
Great.
Awesome, Doc. So we're just going to get straight into the questions tonight. Like I said, there's quite a few.
Okay.
Okay, guys, if you have any questions, please put it in the comment section. If we don't get to your questions, we're going to give doctors details, and you can contact her directly, follow her and DM her on Instagram, or just email her, or go to her website, and you'll get all the details there. So what is PCOS, first of all?
PCOS stands for Polycystic Ovarian Syndrome. I always say, you know, the name PCOS is like a misnomer. You know, it's actually an understatement to say PCOS is just Polycystic Ovarian Syndrome. It's actually a major endocrine disorder or a hormonal disorder, which involves Almost the whole body eventually, but the key organs involved are the liver and the ovary. The brain is also involved because the hormones in the brains, which we call LH, are found to be increased, and that's the hereditary, or the part of polycystic ovarian syndrome that is believed to be hereditary, where the receptors in the brain are actually, oh my word, labor ward is calling, guys, what must I do? Someone is probably in labor or something, please. I'm so sorry.
Okay.
I
Okay.
can't ignore.
Take it, Doc. It's fine. We're going to come back on, guys. Doctor has to do it. So I'll just stay online, Doc. You take the call. You can go off.
Thank you so much. I'll join you now.
Okay. Okay, guys. Sorry about that. Doctor has to go, but she's a doctor. We can't expect her to just ignore that call because it could be any of us. We just imagine it was any of us that needed to, you know, one of us in labor, so we wouldn't want Doc to ignore us. So while we're waiting for Doc, if you guys have any questions, oh, there we go. This is my light. It's working. If you guys have any questions for Doc, I see some of you are actually posting questions. Please let us know. Please put it in the comment section, and I'm going to try and go through all of it. Somebody's asking, is Dr. Q's practice still not taking discovery for IVF? I know there's a thing about discovery. So I think you need to first pay for it, and then discovery actually reimburses you. There is, if you go to our website, www.fertilitysolutions.co.za, for any of you that don't know, you can actually get a loan through Medifin that is connected with us. You go to them, and they actually pay Doc. And then you can you actually pay them off, and I know it's the rates are so much cheaper than taking a personal loan. So if you guys don't know about Medifin, go and have a look on our site, and you can just apply for it. They're quite good, guys. Also with consultations, I'm sure if it's through certain medical aids that you can actually claim it back. If it's just a normal you know, your first consultation and the scan and those type of things, you can actually claim it back from your medical aid, guys. I used to do that. I remember doing that. Does acupuncture help? I have actually heard about it. I can't exactly say that it does help, but I know a lot of women, when they are going through IVF, I know a lot of them actually do acupuncture before or while they're doing it. So Doc's back, guys. We can go on with the questions. Is the mommy okay? The mommy to be?
You know what? I don't know. I hope she doesn't go quick. Someone just came in. She's 5 centimeters dilated. So I hope by the time I have to go do a delivery, we are done.
Okay. Let's go.
Yes, we were just explaining what polycystic ovarian syndrome is. So it basically involves the endocrine system. And the main thing, though, is there is high insulin levels. And high insulin levels are associated with insulin resistance. And that results in women then having high androgens in the ovary. And androgens are male-related hormones. Those male-related hormones, I think I'm also explaining a lot of things here in this, explaining what polycystic ovarian syndrome is, because I want us to understand how do we get these symptoms that patients actually present with as well. So those male-related hormones from high insulin results in high androgens. High androgens results in no ovulation. Male-related, no ovulation. Now, ovulation will then, and also the high androgens result in the excess hair that women get and the lots of acne that women get. That's due to the high androgens. And then with them not ovulating, then it results in not being able to fall pregnant. So it's a metabolic disorder. It's an endocrine disorder, you know, also having fertility effects as well. And I don't know if there's a question about how do you know if there's polycystic ovarian syndrome or how we diagnose it.
Yes, that is actually one of the next things is how is PCOS diagnosed?
Okay. So with PCOS, we have what is called the modified Rotterdam criteria. But the criteria always tell patients, you know, we look for three things. Firstly, we need to make sure that there's no other causes that could be the result of the cause of these symptoms. Then when we've ruled out everything like tumors and medication that patients can be taking and everything else. So we say it's a diagnosis of exclusion, almost like a last resort. And then we find that patients will present with at least must have 2 of 3 symptoms, okay? One, they will present with absent periods. A lady can come in and say, I haven't seen my periods for 6 months or however, or they have what we call oligomenorrhea, where they can menstruate less than 6 times a year. So their cycle will probably be longer than 35 days. So patients will have a 45-day cycle or a 40-day cycle, 50 for that matter. So those then those patients, we say they have oligomenorrhea, so absence of periods or very few periods. Then the second symptom will be they have what we call hyperandrogenism. Remember I said they have high androgens or male-related hormones due to the problems that I have happening in the ovary. So that results in excess lots of acne. So the acne you'll find on the face, they'll have on the chin, on the forehead, some acne on the chest and acne at the back as well. So that's part of the hyperandrogenism, high androgens. And again, they can have excess hair in the male or in male orientation. So lots of mustache. They can have beard. They can count or pluck the beard. A lot of women have to shave or pluck the beard out. They have sideburns. They tend to think that they are very hairy, you know, but only to find that it's actually associated with the syndrome. So they can have excess hair on the belly, on the back as well, on the inner thighs, at the back, and all of that. So there's areas and there's a criteria that we use to actually score them. And then, especially with the Indian race, the criteria has a higher scoring for them because they are known to be having lots of hair. But with other races, then the scoring is a bit less. So they quickly reach the scoring criteria. We call it the Ferriman-Galway score. That's also part of hyperandrogenism. And then they have also what we call male-associated male pattern baldness, where they lose hair, or alopecia, where they find themselves losing hair or balding in the pattern of a man, okay? So if they have, that's hyperandrogenism. And then the third sign is when we do a sauna. And then in the sauna, it's a transvaginal sauna that we do. And then if we find that on sauna, there are multiple cysts that we find there. It's the normal follicles, but with the Polycystic Ovarian Syndrome ovary, we find that there are multiple cysts, and we need to count more than 20 of them that are slightly enlarged or bigger than normal, like 9 millimeters and above. And if you have like 20 or more, then that is said to be a polycystic ovarian morphology of the ovary. So if you have any 2 of these 3, then it is said that you fulfill the criteria of having what is called polycystic ovarian syndrome. So some patients may have the acne and the excess hair and they miss their periods, but they don't have the polycystic ovaries. It still forms part of the syndrome. And then if they don't have the clinical part, then we also do blood tests that will be associated with the high androgens in the blood. I hope it's simplified.
Yeah, and I know sometimes the doctor used to tell me, can you see there's a string of pearls? Is that
Yes.
correct? That's all, they look for a string of pearls, basically.
It's
Your
called
ovaries.
a pearl sign on the ovary because these follicles. Now you can just imagine someone wearing a pearl necklace. So
Mm.
that's how they look. So the center is usually bare, and then instead of the follicles being scattered all over the ovary, they are mostly found at the periphery of the ovary, and they look like a pearl string or a pearl necklace sign. So
Yeah, yeah.
that's the sign that they commonly use.
Okay, I'm just gonna go to the next one quickly. Uh, sorry, guys. Okay, if I have PCOS, should I see a fertility doctor before trying to conceive, or would I see a normal gynecologist? What do you recommend? Or at least do I see a doctor if I think I have
Yeah, if
PCOS?
you see a doctor before trying to conceive, it will be great if you can. It's not always like it's not compulsory, but you
Mm.
find that women with polycystic ovarian syndrome may be having uncontrolled insulin resistance or diabetes or uncontrolled blood pressure because PCOS has long-term effects as well. It can affect the heart, it affects the liver, you can have a fatty liver. So there are a lot of complications of PCOS that patients are not aware of which it will be great if they can see at least a gynecologist or a fertility specialist, even better, for them to plan a pregnancy. It is always best to plan any pregnancy. So before they plan a pregnancy, to avoid complications in their pregnancy, we would love to make sure that their blood pressure is controlled. They don't have metabolic syndrome. They've got good heart function. They've got good sugar control, because once we start off a pregnancy with uncontrolled sugars, right from the onset, as that baby is developing, that baby can develop with congenital abnormalities, defects in the heart, defects in the spine, defect if the sugar is not controlled, and the underlying cause could be PCOS that is not controlled. So it will be highly recommended if they can come and visit us just to say, look, I'm planning a pregnancy and I've got PCOS. I just want to know that all my systems are check, and all systems go. So yes, I would recommend that they actually come for a checkup, because we may even end up delaying. Some patients with PCOS have severe or morbid obesity. And I would say to them, look, falling pregnant at 110 kgs or 130 kgs is a high risk, you know. So can we focus on keeping you alive first and focus on weight loss first, and so that the pregnancy also becomes a smooth one? Because as you go through a pregnancy and you are unhealthy yourself, then the genetics of this baby, the DNA also gets affected, and you are now diabetic during the pregnancy, creating an individual, an offspring that will be at high risk of diabetes and all these complications going forward. So those are the things that we can actually avoid and correct before we start multiplying ourselves and creating small humans through our bodies.
Okay. The next one is, I think you touched on that a bit now, but what can I do on my own to lessen my PCOS symptoms?
Okay, so that's actually a very important as well, and it's a very difficult one. You know, you touch the topic of weight loss. It's not an easy one for anybody. You know, it involves a lot of discipline. It seems like we are being harsh sometimes when we tell patients, please consider your lifestyle. And with the current lifestyle now, with lockdown being an issue, working from home, it has actually made matters worse for a lot of people, because then obesity is suddenly becoming rife, because we have a meeting and walk to the fridge and have whatever and walk to the fridge. So if patients can please just watch out on their lifestyle and focus on dietary changes, and to really be careful on what they eat, the fast sugars and all of that. So the lifestyle is important. And then even though we are under lockdown during this time, we are allowed to take walks, we are allowed to jog, you know, the gyms are now open, and some of us are trying to make our way there and make our summer bodies. So, you know, it is highly recommended. And those are the things that you can actually do on your own. And then to frequently, at least every 6 months or once a year, if you have polycystic ovarian syndrome, please go and get your vitals checked, get your blood pressure checked, get your sugar control. You can do what we call a HbA1c, which is a blood test that checks your sugar control for over a 3-month period at least. So you can get those things done. Get your lipogram done, because there's the whole metabolic syndrome with PCOS. So you want to know that you don't have excess abnormal sugars like the LDLs, and the cholesterol levels as well get affected by PCOS. So get those things checked, and that's what you can actually get to do on your own.
Okay, awesome, Doc. How is ovulation stimulated, especially in someone with PCOS? And onto that, I actually want to add, you know, there's some doctors prescribe the letrozole and some the Clomid with ovulation induction with women with PCOS. Can you just go through that for us, please?
Okay. So with regards to PCOS, there are a few steps. Maybe that it's actually, the question is covering trying to conceive with PCOS now. So there are patients with PCOS that the issue then becomes that they are not seeing their periods, and therefore they don't even know when they are ovulating. So for some patients, it's as simple as them being on, especially those with a high BMI of about 30, them being on an insulin sensitizer. So they can be on metformin, which then, remember I said there's a problem with insulin, and insulin increases androgens, and androgens then result in not ovulation and ovulation, or patients not ovulating. And if you're not ovulating, you can't fall pregnant. So if we are able to reduce the insulin and let the body use up the insulin instead of the insulin hanging around in the bloodstream and wrong tissues, then if we reduce the insulin, you find that women are able to get their periods and ovulate naturally without even getting to ovulation induction. You know, so there's also a lot of products in the markets, especially the inositols and D-chiroinositols that are available. I know if I mention a few products, a lot of people will be like, hi, yes, I'm on the picositol. Yes, I'm on the Insumax Q. Yes, I'm on the Ovaria, and all those other products. So those products are believed to also help with insulin sensitization, and then that helps with just restoring normal ovulation. And then they can actually time their ovulation. You know, this some women know when their body is actually ovulating, and then just that alone can actually help them to conceive. So I've had a lot of patients who just go on that, and we say, look, 3 months weight loss, be on the insulin sensitizers, be on the metformin, and then see me in 3 months if the age allows. And some of them, you find that they're not even completed a year of trying to conceive. And then they'll come back saying, okay, doc, I got my periods. When you gave me the COC, then I waited, then I did this, then I timed, but then for the past 2 months, I haven't seen my periods. I'm like, oh, okay. Then they think it's actually PCOS related, only to find that they actually 8 weeks pregnant, and they're not even aware, you know, because they actually got the timing right and got the things right, okay, and they understood their bodies better. So sometimes it's just a matter of education and proper timing of intercourse, and then women become successfully pregnant. Now, if and that involves just lifestyle and insulin sensitizers. Now, the next step is then to go for ovulation induction. So ovulation induction, we use drugs to actually help the woman to ovulate. And then they can have either timed intercourse, or they have what we call insemination, intrauterine insemination. So with timed, it depends how then they want to fall pregnant. But for us to help you to ovulate, then we can give the first first-line drug is what we call letrozole, Femara. So letrozole has been found in studies to be more superior than to Clomid, superior to Clomid. So letrozole we give in a dose of 2.5, which is 1 tablet a day at minimum, or 2 and a maximum of 3 tablets a day. So we give it from day 3 to day 5, and then women can start timing or testing for ovulation. If the woman, we recommend that if women are on ovulation induction, it is great, especially women with polycystic ovarian syndrome, because they can hyperstimulate. Remember, we said they've got lots of eggs. I said if they have more than 20 follicles per ovary, then we make the diagnosis. So they've got, to them, it's not a matter of not having eggs. It's a matter of having a lot. You know, but that lot is lying dormant. It's like they are sleeping eggs. There are many, but they're sleeping, and they just need a trigger. Okay, so once insulin is reduced, and then we start with the ovulation induction, then you find that we need to time them. So because of them having a lot of eggs, they can hyperstimulate. That is the risk. So many of the eggs can respond at the same time. And that then has a side effect of multiple pregnancies as well. So that is the risk of ovulation induction. So then when we see that they are ovulating, they can do an ovulation kit at home if they are timing themselves at home, or they come in, we do LH levels, and we check the follicles, the one that's leading, and then we know when exactly to time intercourse or to do insemination, whether we're using letrozole or Clomid. So we follow them up closely. And if we find that we've given them drugs and a lot of follicles have responded, it's either we convert that cycle to IVF and actually take those eggs out, or we ask that they cancel the cycle altogether, because we don't want them to complicate from the multiple follicles that they've triggered.
Okay, so okay, we went that we did the one about the multiple, and then why is it always that doctors would recommend contraceptives? I think this is a lot of a question that we get a lot, is like, why are they putting me on contraceptives when I'm trying to when I'm not getting my period and I'm trying to conceive and I've got polycystic ovarian syndrome? First thing doctor recommends is the contraceptives. But why? I think you explained it so well the last time we did this. So please talk about that.
Yeah, so the actual problem is that, as I said, polycystic ovarian syndrome is a hormonal problem. It's an endocrine problem. Now, as women, we ovulate through hormones. And when we don't ovulate, it means also we're having a hormonal problem. So if you don't ovulate, then and you find that you are not actually having your menstruation. So what we do, and the menstruation actually helps us to have a start point. It's like running a race and you're not starting at the starting line, and you just find yourself in the middle. You don't even know whether you're going forward or backward. So starting at the time of the period actually helps us to know that this is our starting line. And you count, because we usually say you take the medication on day 3 of your period. If there's no period, you get patients, doctors tell the patients, take it on day 3, and there's no period, and it's 3 months and there's no period, and they're still waiting for day 3. So yeah, giving them contraception actually helps them to build up this lining. And then the hormones also in the ovary starts with the follicle making process. And then when the lining sheds, that's when they actually are able to get their period. So it's more of the hormones that are given. It's not to actually stop them from falling pregnant. It's actually to trigger that period. It does not treat polycystic ovarian syndrome, but it's there to actually help them to trigger a period for the treatment process to start. Okay. And it's not a long-term contraceptive. It's just for that time, like maximum a month. And once they get their period, then we know this is our starting line and we're going forward. And that contraceptive does not last in your body for 3 months or anything like that. No, it's just during that time. And then we are able to get started with the ovulation induction.
Okay, awesome. Awesome, Doc. Will taking the contraceptives lower my chance of conceiving, especially with PCOS?
No, taking contraception does not lower your chances of conceiving, especially this one that I just spoke about, which is just the once off to get you started back on your period. And even when you go on contraception for long term, remember contraception? I don't also like the term contraception because contraception means preventing a pregnancy.
Yeah.
These are hormone tablets. So these hormone tablets are not there only to prevent pregnancy, but they are also there to treat acne as well. So because some of the hormones in the contraceptive tablets have anti-androgenic effects. So you will be given these tablets because you complained of severe acne. Not because we want to prevent a pregnancy. It's because of the effects of the progestogen in these tablets that it clears out the acne, it reduces the hair as well. So these contraceptive tablets are part of the treatment of PCOS, especially the cosmetic effects. So there are some women who have PCOS and currently they are 25, they are climbing the career ladder. They are not interested in having kids yet until they are 30, but they've got severe acne, they've got severe hirsutism, they're not seeing their periods, they are worried. So if they want to see their periods, we'll put them on a contraceptive tablet, not because we want to prevent a pregnancy, but because the tablet has got other beneficial effects, which is clearing out the skin and reducing the development of facial hair and also regulating their period. So it sorts out the majority of their problems with PCOS. And then once they are ready to fall pregnant, that's when we stop the contraceptive pill and then help them to time their pregnancy or help with ovulation induction.
Okay, I'm actually looking at some of the questions, and I'm actually going to skip past it because we've gone through it. Who should I see to be diagnosed? Again, we went through that, and just seeing you said seeing a gynecologist at least to be diagnosed.
Yes, okay? Yes, to be diagnosed. And then for fertility concerns, if they want to conceive, then it's great to actually see a fertility specialist, because treating a PCOS patient, as I said, they can hyperstimulate with those multiple eggs, and that also can be dangerous if not managed well. So it is best to see a fertility specialist who can then assist if the patients have ovarian hyperstimulation syndrome.
Okay. Another question is, so there's your questions from your IG, Doc. One of the first questions is, what's the go-to IVF protocol for PCOS?
What is the
go-to IVF protocol for PCOS?
Okay, I don't know how deep the person wants to go. It sounds like she some fertility specialist. I don't know if they want me to discuss the drugs or the management, but as far as everything is concerned, or PCOS and trying to conceive is concerned, I want people to know that everything is individualized. If you have PCOS, you are not now classified as one group. Therefore, everybody with PCOS must have this. There are some patients that have PCOS and they have high LH, but they have which is the hormone. Now, I think the person who asked the question will understand better because they are talking about protocol. So there are others that have a high LH, but you find that they are LH resistant, even if it's high. So then there are some PCOS patients that will get combined drugs where they've got FSH and LH, but there are others where we just give FSH only because the LH is already high. So again, we usually recommend to start low and then go slow. And we usually do not give a lot of drugs for polycystic ovarian syndrome patients, because of the caution that they may hyperstimulate and end up in ICU. So we start low with ovulation induction as described, and then should they be resistant to clomiphene or not respond even to the letrozoles, then we can consider putting them on gonadotrophins, and they need strict monitoring if they are on gonadotrophin stimulation.
Okay, we've got our last two questions here. Does PCOS ever go away? Is it treatable?
It's manageable. We don't have a cure for PCOS. Unfortunately, you can take it, it can go all the way to menopause, but it is manageable, very well manageable. We've got patients that are doing very well on with PCOS. They end up managing to fall pregnant, extend their families, close, sterilize because they are done, and then just manage their health aspects, and yes, all the way to menopause. So it is very well manageable, but unfortunately there is no such thing as this is what we give to cure PCOS. No cure, but very well manageable.
Okay. This is a quite a good question, is how do you maintain a healthy pregnancy when you have PCOS?
Okay, so with PCOS, as I mentioned, all the systemic effects of PCOS, so it's very important. I think during the antenatal visits, we do a systems check, and it's important to check as I said, the cholesterol levels. Firstly, just checking their blood pressure management, going through urine dipsticks, making sure that we check, making sure that their blood pressure is controlled or they do not develop hypertension. Eating healthy so that they don't gain excess weight. If they already have issues with weight management, we don't recommend that they gain more than 12 kgs throughout the pregnancy. And again, doing blood liver function tests, looking out for those lipograms, and checking their glucose as well, making sure that they don't develop gestational diabetes mellitus. And if they do, we need close monitoring of the sugar. Treatment for the gestational diabetes, be it lifestyle only if it's not too bad, or going on to give the metformins all the way to insulins, depending on how how severe is the diabetes or the gestational diabetes. So it really needs close monitoring of those conditions that we know are associated with the complications of PCOS.
Okay, I'm actually not going to keep Doc. I see there's quite a few questions, guys. But as you know, Doc's got a lady in labor, so I don't want to keep her any longer. I just got one last question. And also everybody who's sent questions, you guys please mind sending me a DM. I will send it straight to Doc. We're actually going on to Doc's Instagram and sending it to her. Maybe there's something on there that you can see, Doc, that you can ask, that you can answer, one of the ladies.
There is a question here, Dipono Finger. Does the doctor need to take you for operation, hysterectomy and laparoscopy? Is there other options besides doing these operations?
Hysteroscopy. Is she not maybe talking about a hysteroscopy? Is she maybe not talking about a hysteroscopy instead of a hysterectomy?
Yes, I think there was a misnomer there. So probably a hysteroscopy and a laparoscopy. Okay, hysteroscopy will be to check inside the womb, mostly unless maybe there's other pathology that the doctor is suspecting, maybe inside the womb. But also in the long run, women with PCOS, because of the hormones, can then also have what we call endometrial hyperplasia, which can eventually lead to cancer of the womb or the lining of the womb, endometrial cancer. So hysteroscopy can be required if doctor is looking towards those lines to rule that out. Laparoscopy it can be part of treatment. It's not a must for everybody, but there is what we call ovarian drilling, where a laparoscopy is done as part of treatment for PCOS, as a way of trying to reduce the androgen production of the ovary. So we go in laparoscopically and just make 4 small holes on the ovary, just for not for more than 4 seconds each, and it's done on both ovaries. So if the doctor is going in to do ovarian drilling, that's the one indication for a laparoscopy for patients with PCOS, but that's a surgical intervention. It's not compulsory that everybody does that, and instead of ovarian drilling, then maybe one can just go for ovarian stimulation or ovarian induction.
Okay, I actually had ovarian drilling twice, and I conceived on the first round of ovarian drilling. So that actually does work for some, but doesn't work for everyone. But I mean, actually does.
It's one of the options. Yes.
Yeah. Maybe there's one more, doctor, that you want to go through, and then we can say goodbye, and everyone can just DM us the questions.
Please recommend contraceptives for someone who still wants to conceive. I hear that injections are not ideal if I still want to conceive. Okay. Okay, for polycystic ovarian syndrome, we recommend contraceptive tablets that will help, especially with acne and hirsutism, and those are contraceptives that have what we call anti-androgenic effects. So those are contraceptives like a tablets, like a Yaz or a Yasmin or a Jeanette that has cyproterone, and Jeanette and Diane. Jeanette and Diane has high estrogen content, 35 micrograms of estrogen, so they may be associated with blood clotting. So the lower content of estrogens are those of Yaz, like a Yaz. So usually with me, that like a Yaz is like a primary preference, because then they get the anti-androgenic effects and the contraceptive, and they are regulating their periods. Voila, you know, it's like an all-in-one benefit. Then ones that have progestogen only, like injections, they are long. They are the injections, the implant, the Mirena, and the copper forms part of what we call the LAC contraceptives, the long-acting reversible contraceptives. So they may not have good effect on the skin and the hirsutism, but they just form contraceptives, and they are reversible. The injection is also reversible. You may, it's just that they can take like 3 to 6 months before they come out of the system. They don't make you infertile. It just takes a bit longer to come out of the system. So, but they are reversible as well.
Okay, perfect. Thank you very much, Doc. Doc is looking at more questions. You know, I'm just taking, I don't want to keep you. I'm just scared that I don't want to keep you too long, Doc. But yeah, guys, please DM us, send it to us. I will send it straight to Doc, or just go to Doc's Instagram page and you can actually DM her, and there's definitely someone that just immediately answers you and stuff. Thank you very much, Doc. All the best for this evening, and your lady that's going to have a baby. Congrats. So have a great evening, and thank you again for taking time out to do this for us. Thanks, Doc.
You are most welcome. I'll be happy to answer the questions on the side, and all the best to all our ladies, and keep smiling.
Awesome. Thanks, Doc. Bye.
All right. Keep well. Bye.